request all our chairperson to kindly take your respective seats. In the speaker first. Dr. Nirdesh Sen sir, Dr. Sengar sir and Dr. Anshul to kindly take your respective seats.
We are using for so many years. So, would you like to replace this with the Fineron?
Is there any trial head-to-head comparison
for this subset of patients? Diabetic kidney disease.
In kidney disease, diabetes, hypertension, heart failure, in any
diabetic kidney disease with electron versus placebo, there was no benefit in diabetic kidney disease. Fineron and placebo, there is benefit. So there is no point in comparing both these molecules because there is no benefit.
But there is no comparison between spironolactone and fineron.
placebo में benefit नहीं आया, तो आप compare क्या करोगे? Spironolactone has no use in diabetic kidney disease. But in heart failure, you can say heart failure there is use, fineron it has use. So there could be a crossover trial with both these molecules.
Actually, we have, but only albuminuria reduction is only seen with fineron. And what is the advantage? Albuminuria is a surrogate marker for CVD risk because of associated inflammation. So it is reducing inflammation by reducing albuminuria and reducing the progression of CAD.
But data are with the diabetic, right? On diabetes and CKD.
Data with, but there are studies are ongoing for CKD. The initial there is a benefit, and there is a study called Find CKD trial. The result will come in 2026.
Not published.
Find CKD जो trial चल रही है, but result जल्दी आएंगे.
But right now they were only diabetic CKD.
But there is a trend towards
Whether it is hypertensive nephrosis, whether it is IgA nephropathy, in all these the fineron trials are going.
Basically, this is an anti-inflammatory drug which decreases fibrosis and inflammation.
So,
मतलब to be used earlier on before the patient develops heart failure or goes into frank CKD. Detect the patient as early as possible.
But present recommendation is only on diabetic.
Only on diabetic.
Another question is, sir, whether if the patient is having CKD and we are starting fineron, suppose his serum potassium level is there any correlation with what dose we should add at blood potassium because it causes hyperkalemia?
It's for potassium and serum creatinine, and then you step up to 20 milligram.
Potassium should not be more than.
I want to just have some corrections because I already dose for GFR more than 40 is 40 mg, and you should start with the 20 mg and you should try to reach it to the 40. And the whose GFR is less than 60 and between 25 to 65, you should start with the 10 mg and you should try to reach to the 20 mg.
My next question is related to Dr. Nirdesh. What is the advantage in real world setting over spironolactone if we are only comparing heart failure? We are having fineron versus spironolactone in heart failure versus not comparing, not seeing the heart kidney disease.
Told it by second last slide when I compared all these three molecules, and because this molecule has come up for the hyperbaric preservation fraction. Although electron was studied for the preservation fraction, but it could not show any benefit. Even the FSS study, Epinephrine was also studied for the heart failure with preservation, but they did not materialize. So this molecule till now is recommended for heart failure with preservation fraction or mildly reduced ejection fraction. Whenever your heart EF ejection fraction is less than 40%, it is not endorsed nowadays. But in the future, it may come up because the trials are going, many trials. They are in the phase 3 trials. The result will be published by the end of 2026 and 27. So the next guideline we will see this molecule.
It is beyond doubt in diabetic kidney disease that finerenone should be used. But in cardiovascular diseases, it has only shown reduction in hospitalization due to heart failure. It has not clear-cut shown any survival benefit or cardiovascular mortality benefit.
It has shown survival benefit. The major result is driven by the hospitalization heart failure rates. But if we consider cardiovascular mortality and heart failure, then it is so significant. But if we consider individual primary outcome point, then only the heart failure hospitalization was significantly reduced.
The same is also these molecules are reducing the population to heart failure, not cardiac mortality. One my query is that it is evident from different studies that rate of reductions of UACR and EGFR is more with this phenomenon as compared to this SGLT2 inhibitor. In diabetic patient, definitely we are using SGLT2 inhibitor before phenomenon. And when we found that patient has come with increased UACR or microalbuminuria, then at which point we have to initiate suppose we are not using SGLT2 inhibitor in diabetic patient and patient come with microalbuminuria, then we start this combination phenomenon with SGLT2 at the spot, or we have to initiate the first SGLT2 and see the results and then escalate the we go to other drug. What guidelines say? What KDIGO guidelines say? I am not talking about these two trials because they are very small trials, 7,000 patients, 14,000 patients. There are millions of populations of CKD, diabetic series in the world. And we are investigating only 7,000, 14,000 patients. It's not what KDIGO guidelines say, sir.
Let Professor Second.
What the KDIGO, FALO and this thing confidence trial, I can say the benefits should be given at the start. Maximum tolerable ACE inhibitor, ARB, and this thing, SGLT inhibitors, and phenomenon. If the patient is microalbuminuria, one of the slides I have shown, if you start at the age of 50 years, you are getting benefits of 5 or 7 years. So don't lose this benefit.
But his question is a bit different. The patient है उसका SGLT2 use नहीं हुआ है.
SGLT2 नहीं हुआ.
और इन्होंने तो ये भी नहीं बोला कि वो ऐसे इन्वर्टर अभी यूज कर रहा था कि नहीं कर रहा था. भाई CKD के पेशेंट है.
नहीं सर.
Why don't you start?
नहीं सर. मैं ये कह रहा था
अगर कोई भी यूज कर रहा है तीनों दीजिए, एक यूज कर रहा है तो बाकी दो भी कीजिए.
नहीं 4 यूज कहती है. This is a preventive drug using already, but it's not using SGLT2 inhibitor. Yet using some other anti-diabetic drug. And when you found microalbuminuria,
there is
combination में ज़्यादा
They are not compared to the different class.
combination में
It is
ज़्यादा
add-on drug for SGLT2, but it is not antidote.
कैसी क्या आपने बोला?
Add-on drug हो गया. This is add-on drug.
SGLT2 is add-on drug or phenomenon is add-on drug in diabetic CKD.
right now phenomenon.
Those come after.
But trials have
नहीं I want comment from Dr.
It already has established its position number 1, but it has come after that. So it is add-on drug.
Add-on drug.
जो पहले से है उसको थोड़ी हटा सकते हैं. We should come like that. RAS inhibitor is already established in decreasing the progression of kidney disease. So we should use that.
If we look the initial trial, EMPA CKD trial, the DAPA DKD trials, the all trials say that when you found diabetic with increased UCR, you have to initiate, you have to give DAPA SGLT2 inhibitor. Now
they said shown that it comes. DNMO, 9 patients comes. I think start 3 all the drugs.
all the 3 drugs.
Best is to start all 3 drugs. So first is AC inhibitor.
First is ACE inhibitor or ARB. They are huge, big trials.
Big trial, big experience.
Thereafter
नहीं, but why won't you start it?
वो कुछ नहीं है सर, वो तो सही रहेगा, वो तो सर सही रहेगा.
क्वेश्चन एक मिनट क्वेश्चन क्या है सर क्वेश्चन का रिव्यू कर लेंगे वो दे दीजिए
for proteinuria. SGLT2 inhibitor and finerenone are add-on drugs. अगर ACE inhibitor से ही proteinuria खत्म हो जाता है, तो हम SGLT2 और finerenone क्यों ऐड करेंगे?
Definitely, we have not.
Sir, ACE inhibitor से
logical action is different.
This trial says that we have to add these drugs after maximum dose of ACE and ARBs.
That is the same thing. That is ये जो आप अंशुल आप
Your target is to reduce.
Sorry. जो अंशुल कह रहे हैं, I don't agree with that. addition of finerenone has to be done after the maximum dose of ACE inhibitors. You can't use as such in first trial. Trials जो कह रही हैं आप SGLT2 use about SGLT2 inhibitors, yes, there is no recommendation like that. But for the person you have already used ACE inhibitors at maximum doses and then it is not reducing, then add finerenone. वो तब कहता है, और जब भी उसके बाद भी आपका जो EGFR है, it has to be more than 60. Then and UACR है, it has to be more than 30, not less than 30. Then and then use it. Otherwise, it is of no use. Thank you.
So again, question arises that
You have to be very clear
when
about
diabetic patient
You have to be very clear.
without hypertension, when we initiate ACE inhibitor, suppose diabetic patient come without hypertension with normal blood pressure, when we initiate ACE inhibitor, ACE inhibitor is given after increase UACR or increase hypertension or without these two.
There are two indications. One is hypertension, one is albumin.
Hypertension है.
नहीं, अगर hypertension नहीं
एक मिनट, patient hypertension नहीं है, patient का UACR less than 30 है, why do you use?
So,
नहीं अगर why भी है तो आपको नॉर्मोटेंसिव स्टार्ट करना है.
So this is the hypothetical situation because most of the patient.
एक मिनट, जो आपकी बात का आंसर भी पूरा नहीं हुआ. पेशेंट का UACR लेस देन 30 है. पेशेंट को आपने डायबिटिक वो इज डायबिटिक नॉर्मल ब्लड प्रेशर है. मैं अभी अब यहाँ पे आपने क्वेश्चन तो ये था ना आपका, यहाँ पे आपको फिनेरेनोन यूज नहीं करना है ना, आपने कुछ यूज करना क्योंकि लेस देन 30 है. आपको जो यूज करना है डापावेल यूज करना है. क्यों यूज करना है? क्योंकि एवरी डायबिटिक इज ग्रेड 1 हार्ट फेलियर.
बिल्कुल सर, एंटी फाइब्रोटिक
इफेक्ट है उसका, तो आपको यहाँ डापावेल यूज करना है.
Then we have to see the ADA guideline. ADA guideline. What ADA guideline says that if we see the cardiovascular risk factor. If patient have any cardiovascular risk factor, we have to initiate the SGLT2 inhibitor first drug.
Yes.
If it is not affordable or not tolerated, then start second drug is the SGLT2 inhibitor.
सर ये आपका मन में कह रहा है. हार्ट फेलियर है ना, तो है तो दो.
अभी जो प्रॉब्लम आ रही है हमारी, अभी तो आपने डिस्कशन कर लिया. अभी जो मेन प्रॉब्लम है फिनेरेनोन के पेशेंट में आपने सीकेडी में कोई स्टडी, क्योंकि स्टडी नहीं हुई है, इनको सब अभी फाइन जो ट्रायल चल रही है उसके इसमें क्लिनिकल वेट करनी चाहिए. तो उसकी अभी जो ट्रायल चल रही है उसकी लेटेस्ट वेट, ट्रायल्स आर गोइंग ऑन, रिजल्ट्स आर इन फेवर ऑफ फिनेरेनोन. क्योंकि एंटी फाइब्रोटिक ड्रग है ना, तो उससे फायदा तो होगा ही होगा. असली कहानी जो है, जो मेरा क्वेश्चन है आपको, क्योंकि सबने क्वेश्चन कर लिया, किसी को क्वेश्चन नहीं छूटा. मेरा क्वेश्चन ये है कि हमने ACE इनहिबिटर वैक्सीन यूज कर लिए, हमने डापा यूज कर लिया, SGLT2 इनहिबिटर, एम्पाग्लोफ्लोजिन या आपने डापा जो भी यूज करना चाहते हैं. तीसरा हमने यूज कर लिया आपका फिनेरेनोन. क्या एक कॉम्बिनेशन ऐसा बन सकता है कि जिसमें हम यूज करें GLP-1 RA इनहिबिटर?
ठीक बात है.
हाँ, ये बड़ा इंपॉर्टेंट फैक्टर है.
बिल्कुल ठीक है.
हाँ, जिसके बारे में हमने कोई बात ही नहीं करी है.
अगर within months this combination must come. This month combination must come.
GLP-1 एग्रेसिव होना चाहिए. बिल्कुल ठीक बात.
Because this confidence trial is come to that purpose only.
सर जब ये ऐड आ जाएगी तो मेरे से 160 साल तक जिएंगे.
ये तो आप अभी भी नहीं सकते.
फिर कह रहे हैं सर, there is no mortality benefit. Either in finerenone or in the
शो किया उसमें.
नहीं mortality sir.
ongoing treatment ले रहे हैं, then all cause mortality
14% है भाई. total mortality benefit is 14%.
Sudden cardiac
जो hospitalization है
नहीं, in diabetic CKD it is 37%.
in diabetic CKD.
किसका?
In diabetic CKD there is 37% mortality benefit.
डायबिटिक सीकेडी.
एक क्वेश्चन मेरा डॉक्टर निर्देश से अभी यही इसी डिसीजन के ऊपर, व्हाट इज द स्टेटस ऑफ फिनेरेनोन इन अ पेशेंट विद हार्ट फेलियर विद प्रिजर्वेटिव हार्ट फेलियर? अभी पर से अभी हम स्पेसिफाई नहीं करेंगे. What should be a place in therapy? Is it an add-on? Is it a first line? It is a optional.
So first we should distinguish it between the heart failure with reduced ejection fraction or preserved ejection fraction. We consider majorly. If it is not heart failure with reduced ejection fraction, though in 2023 the ESC guideline clearly recommended it class 1 with label A evidence, and SGLT2 inhibitor is also class 1. So we consider, because both have different mechanism of action, so we consider both drugs simultaneously if the patient is requiring these two drugs. Because the heart failure with preserved ejection, we have to manage the comorbidities, and ultimately the inflammation, we have to halt the progression of inflammation. So we should use these two drugs simultaneously. And before this talk, I was also not aware much about this drug, and by doing this talk, I studied and I found I was lacking use of this drug. So I will start using this drug with both hands, those who can afford.
I think this is only for
MRI is the pillar, but not Finerenone.
Yes, that is my question.
where kidney disease
Diabetic, why? हमारा question जो है, that is with heart failure. What is the current Heart Failure Society of America recommendation? Where does this drug stand? अभी add-on और optional drug.
ये सब बड़ा स्टार्ट है
non-diabetic
SGLT inhibitors and
not recommended.
एक तो कमान की गोली बना तो सबको देना.
In fine heart study, it has shown reduction in the fine heart study is also studied in around 5,000 patients.
In fine heart study is not on diabetic patients.
So it is
हार्ट
used.
फेलियर में
Heart failure.
Heart failure.
बेसिकली फाइन आर्ट्स एक्सेप्ट जो ट्रायल है वो हार्ट फेलियर पेशेंट्स में है, डायबिटिक हार्ट फेलियर है।
Heart failure.
और उसका नंबर उसका बहुत बड़ा है फाइन आर्ट्स का,
5,000 patients.
हाँ तो उसका नंबर बहुत बड़ा है। और वो कहता है वो
This last year in
वो ये कहता है
2020
खाली प्रिजर्व्ड पे नहीं है, इट इज गोइंग टू बी इवन ऑन रिड्यूस्ड। हाँ
No, reduce में other studies है.
less than 40 पे नहीं है.
No, अभी it is studied in fine heart. There are other studies like confidence, इसका भी heart failure studies है.
ये उसने कहा माइल्ड
इसका
रिड्यूस
मतलब है
नहीं है,
कि नॉन डायबिटिक में भी
जरूर कराना चाहिए। यूएसआर इज इम्पोर्टेंट इन्वेस्टिगेशन और ये हर लैब में अवेलेबल है मेरे ख्याल से। मैं जहाँ मैं कराता हूँ वहाँ अवेलेबल है।
छोटी सी पोर्टेबल मशीन आती है मेरी क्लिनिक तक।
नहीं मैं चलो वो तो खैर बहुत अच्छी बात है, हम लोग बहुत ज्यादा नहीं कर पाते इन्वेस्टिगेशन, लेकिन यूएसआर इज नॉट दैट डिफिकल्ट टेस्ट या इट इज इजी। नंबर 1 ये हमने आज सीख ली डॉक्टर सेंगर से, डॉक्टर निर्देश से ये सीख ली कि यदि हमारे पास प्रिजर्व वाला भी पेशेंट है, खाली डायबिटीज का पेशेंट भी है, वी शुड थिंक इन टर्म्स ऑफ फिनेरेनोन और SGLT2 इनहिबिटर्स। और डॉक्टर अंशुल तो पढ़ाते ही रहते हैं कि यूज होना चाहिए।
20 mg की क्या कॉस्ट है?
कॉस्ट ज्यादा है।